speak today about intersectoral collaboration and community engagement in path to health equity. A couple of disclosures. First of all, like you said, I am passionate about health equity. I am funded by a KBR Foundation grant for 20% of my time. And these are the goals and objectives that I'm hoping to cover. Looking at applying, assessing community engagement conceptual model to improve health equity. This is one of the newer conceptual models that was recently published by the National Academy of Medicine through an opinion. Advocate, utilizing the equity and empowerment lens framework, which you all have heard a lot about from Jennifer Eggers, and then be inspired to start improving health equity in your own community through intersectoral approaches. So let's just start with the situation, okay? This is a situation for the work I'm going to present. North Carolina's Hispanic population is now over 1 million people. 11% of the population of the state. It's a state of 10 million people. The Latinx population has grown steadily in many urban and suburban counties. So you see that the darker the blue, the more Latinos. And I always say the more counted Latinos there are, right? Because you know that historically marginalized populations often are counted. Truly, they are largely linked to work in pork, turkey, and meat processing facilities, which are marked all over the states. North Carolina is the largest employer of meat packing, larger than Texas even, in meat packing, poultry packing fields. And where I work, 1 in 7 children in rural lives in an immigrant family, most of them immigrants from Latin America. This is a picture of a large Catholic mass service at Immaculate Conception Church. So I'm going to start briefly with a clinical scenario. This is the fall of 2019. And I'm not going to do this video because we don't have time. Maria has been seen in the emergency room and multiple urgent care and office visits since school started. She was complaining of abdominal pain. Nobody could figure out what was going. So we had been meeting with community-based organizations about the stories like Maria's, like this child's story here. Oops, sorry, I don't know what happened. So let's see what's going on in Maria's home. Should be able to. Video. It was working earlier. I'm in the wrong presentation. No, this is the one. Sorry. So it worked before. It's because I'm on Webex. Right, so you won't see the story. When you receive this, you will hear it. Okay, you will see the story. And the story was that we were seeing multiple children afraid, knowing that their parents could be deported. We started seeing there were ICE raids in the schools. ICE came in and picked up parents as they were coming in to pick up children outside of the school. This happened during the school year, right before the pandemic started. So that's kind of where we're at. This is where our situation is. And then the pandemic started. And times of crisis require having done community engagement to improve outcomes and address equity. The Assessing Community Engagement Conceptual Model proposed by a group from the National Academy of Medicine centers community engagement and core engagement principles with 4 propellers, and you see the 4 propellers. So we think about community engagement, and that has to propel strengthening partnership and alliances, expanded knowledge, improve health and healthcare programs and policies. And if you are doing this, following all of the elements of the model, you should end up with thriving communities, right? So the idea here is that we have to think about conceptual models and looking at what is it that we're not doing in order to be able to achieve health equity. And I'll go through some examples. Another model applicable here is the use of the equity and empowerment lens with racial justice focus, which you all have heard a lot from Jennifer Edgos. And in fact, this was adapted from Sonali Balaji. And I learned this model from Jennifer Edgos when we worked together in Family Medicine for America's Health Equity team. This is focused on impact in the areas of people, place, process, and power are the 4 elements of that lens that I will share today as well. So as the pandemic started, we started looking at people. Who is positively and negatively affected by this issue and how? Who are the people in my community most likely to be vulnerable to the issue? What are the physical, spiritual, emotional, and contextual effects related to the issue? And how do people perceive barriers? Now, let's have a reminder of the factors leading to vulnerability. I like this slide from the World Health Organization that tries to make sure that in a visual way, when times of crisis occur, what are the factors? Which are the communities that are going to be most vulnerable, right? As seen in this slide. And this is to prepare for disasters and severe crises. Now, I will argue that a lot of our communities are living in a time of crisis for the pandemic. And we are continuously having crisis. So as a group, as a population, unfortunately, look at the Hispanic community in Carolina, we can check off multiple of these factors leading to increased vulnerability for them. This was happening before the pandemic started. Poor access to healthcare and health services, food insecurity and malnutrition, marginalization, working or living in overcrowded or insufficient infrastructure, highly dependent on the informal economy and wages. Yet also, we could also think that for them, the system of government was, in fact, system where they fear it. So we were already coming off of times when there was a lot of political backlash against most immigrant communities. The idea of the bad hombres from Mexico, et cetera, the rise, the ICE raids, etc. So there were so many ethnophobic politics and immigrant sentiments, creating this otherness of a population not recognized as essential to the economy, the state, or the country. In North Carolina, if you eat during a lunchtime, most of the time it has come through immigrants' hands. 95% of the immigrant workforce in rural Carolina comes from Latin America, mostly from Mexico, but also Honduras and Guatemala. One of the many factors that place the Latina community at risk during the pandemic, many were tied to their economic contribution. While the world was temporarily closed, they were overrepresented in frontline essential jobs without proper protection. And we started seeing the outbreaks in the meatpacking industry, dealing with economic pressures such as minimum wages that limit ability to take time off work when sick. And even important factors like family togetherness and support that normally offer resilience, in the case of the pandemic, contributed to further viral spread because of the multi-generational status of multiple families living together, one mother in one family taking care of all the children while everybody else goes to work and everybody, so the moment of spread was significant. When the COVID-19 pandemic hit North Carolina, it unearthed deep inequities affecting the Comunidad Latina, making headlines in many networks. We saw a rapid increase in COVID cases and hospitalization. This is data at the beginning of the pandemic from Durham County, where I work. Latinos are 13% of the Durham population, but they became 70 to 75% of cases, positive cases tested. And for the first time in life, at that time, 15 years, at Duke, I started getting phone calls from the intensive care unit directors to understand why was it that normally in their regular data, maybe they will have 2 Spanish-speaking people in the ICU, and suddenly most of the patients in the intensive care unit in May, June, and July were Latinos at a younger age than the patients that initially they had seen. Situations like this will require using community engagement to advance health equity. We talked a little bit about that model. In community engagement is that central focus of that conceptual model. Engagement of the community must be ongoing in a movement towards outcome. It's only with community engagement that it is possible to achieve and accelerate progress towards the goal of health equity to transform systems for health. The core principle of community engagement include approaches grounded in trust. You don't build trust immediately. It takes time, but it also takes walking in with the community. As bidirectional, we always talk about the low literacy of our communities, and are we literate enough about what their literacy, how they part of that community is to be inclusive, really a hard area to get. Has to be multi-knowledge that all of learning programs should be shared. How many boards are not really representative of the community has to be ongoing, co-created, and co-equal if we really want to march towards health equity. Participants should be considered co-equal. The need for a collective response led to the creation of Latin19, an amazing coalition of passionate advocates for our community. I co-founded Latin19, the Latinx advocacy team and interdisciplinary network for COVID-19 in March of 2020, when understanding those factors of vulnerabilities that I was talking about, we started getting together several Latina physicians within Duke University, started being called by community members, the school district, representatives of the community. And I had just learned how to use Zoom, and I said, let's open the Zoom meeting, and we started meeting on Wednesdays at noon. We meet every Wednesday at noon. I never dreamed in March of 2020 that 3 years later we will continue to. We're meeting every Wednesday at noon, 166 meetings and counting. And still this last Wednesday, right now they're meeting, they're about to start meeting. There are about 50 people that are still joining. Among the categories of domains of measurable outcomes, again, going back to that model that I was sharing earlier, is strengthening partnerships and alliances, defined as how participants emerge from engagement with new or improved relations. How and what are the benefits that are carried forward? This domain also reflects the qualities of leadership that allow alliances and partnerships to be strengthened, and it has the following 8 indicators. Again, diversity and inclusivity, the creation of partnerships and opportunities, acknowledgement, visibility, recognition, maintaining those sustained relationships. There's mutual value, trust, and shared power. Latin19 is a multi-sectoral group representing multiple disciplines, institutions, and systems, Latinx and allies. Looking and following on that example. When we talk about place, going back to the health equity, the health empowerment lens, what kind of positive place are we creating? What kind of negative place? How are resources and investments distributed? And how are we considering environmental impact and environmental justice? And during those meetings, we started hearing about experiences of discrimination or patients getting lost in the health system, leading to warranted mistrust. Members of the community started coming to the Latin19 meetings because they started seeing that in this place, We will hear, we will listen, like it happened when Yolanda Guzman, an internal medicine resident, a chief resident, listened to a community member talk about people's experience during their admission to the ICU and the lack of communication with the family members. They were calling them the disappeared. For Latin American countries that have gone through dictatorships, for me who grew up in Argentina, the issue of disappearing people is real. It's traumatic. Families were calling the ambulance, and suddenly people were disappearing into the system. They couldn't find them. Sometimes admitted as a Latinx John Doe, sometimes last names transposed, so they're looking for Viviana Bianchi. Like my name is two last names, they will put one last name and not the other in the name, so families couldn't find them. We started talking about the disappeared. So she started working with members of the ICU to raise awareness, to create guidelines and action items to positively impact care provided, and ideas on how to resist dehumanization. One of the things that they were seeing was that they couldn't extubate Latinos because they were coming to talk to them in English. And if you're being spoken in a language you don't understand, suddenly, they're trying to extubate you, you tune them out until they brought an interpreter to start talking in Spanish, and they will wake up. And then they will actually be, thinking about many things that were impacting what was happening. Making sure that requesting an interpreter became a part of the flow of the care of those with limited English proficiency. Making sure the chaplains were included in the care. Reverend Oliver, who had grown up in Latin America, became a huge member of our whole team, participating in Latin 19 meetings, and also being able to advocate inside the hospital. In another meeting, we heard that the fear of being separated from their babies is testing positive for COVID-19. Latina moms started to avoid the hospital or will deliver at home or will come in fearful, traumatized by the possibility of being separated from their babies. The border between the community and the hospital, the experience of children being separated at the southern border with Mexico, being brought into that border between hospital and community. The experience of trauma was real. So our colleagues in OB and family medicine with obstetrics started working on multiple different campaigns to allow the Latino community to know that coming to deliver at the hospital was actually a safe place. We saw that the early pandemic response had first data initially not recorded by ethnicity and race. So we were hearing from the community how affected they were, but initially there was no numbers, so we didn't know. You have to collect the data to know who's affected. There was limited material in Spanish, no inclusion of the community in the decisions that were made. The press became our ally, reporting what was happening. Talking about power that you were talking earlier, a lot of people, you have the press, you have journalists, you have the press coming into the Latin 19 meetings. Why not? This is something that is important to everybody. And that they became our biggest allies, listening to the conversations, understanding what was happening, and really informing with the right information. Process. How are we meaningfully including or excluding people who are affected? What policies, processes, and social relationships contribute to the exclusion of communities most affected by inequities? And what empowering processes can we initiate? One of my family medicine residents, they started mapping our census block data from 2010. That was the earlier one, the latest one that we have on ethnicity within Durham County, and started mapping it against the testing sites at the beginning of the pandemic. So when you see here in green are Black communities, in orange, Hispanic communities, white, Asian. This is where the university is. And you started seeing that all of the testing sites where you could put a line across the city, wealth, an educational level, and all of the testing sites were along that site. And it wasn't until our department opened something in Fulton in July. Now the first cases have happened in March. We are now here, Latino community significantly more affected. And in Lincoln Community Health Center, our residents worked together with them to open the sites. The Durham County COVID test site was the one that we started. It was a partnership between Family Medicine and Community Health and the Durham County Health Department. And they will be referring people directed, contact tracers, students, medical students, physician assistant students, all under our umbrella started becoming tracers. So talking about empowering process, can we initiate this multi-sector partnership for health equity gave all of us strength because we started feeling, we started seeing that we were working together to make a difference. The second domain, expanded knowledge, refers to the creation of new insights, stories, resources, and evidence, as well as the formalization of respect for existing legacies and culturally embedded ways of knowing that are unrecognized outside of origin. One of the things that we started guiding our health system was to understand our community more. The stories that we heard during our Latin 19 meetings helped design the strategy and topics for the public service announcements, radio, research projects, and material that we started to develop. Together with community health workers that we trained to do testing, we went into neighborhoods and parking lots of businesses frequented by the community to offer testing and provide guidance to those who were testing positive for COVID. We designed curriculum together with the community partners, training them on how to have the conversations, guiding every PowerPoint presentation we did was with them. Doctora, eso no sirve. That's you have to say it in a different way. About vaccines, the use of PPE, how to do the testing. They taught us how to best address social drivers of health in ways the community. The arrival of here brought all of us hope. Doing vaccination clinics felt like a test to the soul. There was something more tangible than the problem to do. Working with community workers to expand our health system reach, vaccination events in places where the community already trusts, like churches, and the Latino Community Credit Union. The Latino Community Credit Union became one of the biggest allies that we could have. Linking vaccines to job fairs, adding monkeypox vaccinations later on when monkeypox became an issue in our state. We started a community health promoter program for health literacy. Now, no longer just addressing issues of not just COVID, but then looking at chronic conditions, misinformation, teaching mental health, accessing healthcare. Getting feedback from the community was key, and seeing, always measuring where we're going and what kind of outcomes. The different responses that we're getting about each one of the different classes that we provided. Collecting data in a bi-weekly manner, we were training 27 community health workers on issues of health literacy. Was paid to be able to do the work and then go on and connect with communities and collect data of how the community was learning. The third domain of the conceptual model is improve health and healthcare programs and policies. This is the stated goal of many partnerships. However, creating programs and policies that communities want and will use is a prerequisite to effectiveness in real world settings. How many times we get grants for programs that if we were to be presented early on to the community, they would look at us like, why? How is this going to matter to my community? How is this going to be effective for us? So if we want to be effective in real world settings, we want to require alignment between those who design the programs, the services and policies, and those who are expected to use them. We use this endemic approach initiated by Dr. Rosa Gonzalez Guarda in the School of Nursing, with the Ser Hispano project. The Ser Hispano project precedes the pandemic. She's been working with this project for a long time. The idea of integrating the understanding and care of the multiple epidemics. Happening my thing here. Am I off?
That's what's being shown. Yeah.
Okay. My Webex here is just getting reminded of a meeting on the computer here. I'm sorry. So looking at the multiple epidemics and what are the factors of resilience? What are the issues that actually help communities? Feminism, ethnic pride, social support, and optimism. Paired or against all of the other epidemics disproportionately affecting the community. We became involved in policy change. We have multiple, I first was asked by the Department of Health and Human Services to help with the pandemic response as a trusted messenger for the community. And for 1 year, 50% of my time became time for the North Carolina Department of Health and Human Services. But one of the bigger key issues has been to really help appointing members of the Comunidad Latina to multiple committees and services within the Department of Health and Human Services. As the pandemic evolved, the community shared with us about serious mental health problems. We recognize the immense need for mental health access and training in the community and partnered with our Duke Office of Durham and Community Affairs to obtain a grant to El Futuro as a mental health service agencies for Latinos within Durham and actually North Carolina that started going on training about how to manage this mental health crisis. And as a result, El Futuro provided free training in Spanish on mental health first aid and stress management techniques for more than 400 community health workers in 39 counties in this. We partnered with ISLA to create Latinx Youth Ambassador Program. ISLA is a special program where families of children who go to school in English, but they're Spanish speakers, have like a second school where they do on weekends, they learn everything in Spanish. We're currently involved in gun violence, public health and youth prevention. That we're seeing an increase of use of guns among young members of the Comunidad Latina and trying to figure out how to prevent further problems. We now are funded from the KB Reynolds Foundation with several different teams within both Latin-19 and our departments to increase the enrollment of currently uninsured but eligible members of the Comunidad who identify as Latino in both Medicaid and ACA plans, with pillars for addressing policy, navigation and communication, and education and training. Again, planning, we have done multiple, for a full year, we did multiple team meetings with members, representative members of the community and community health workers to figure out how do we aim to, for the community to understand the importance of getting insurance. NCCare 360 is the first statewide network that unites healthcare and human services organizations with a shared technology that enables a coordinated community-oriented approach. So as a physician, I can do a screening on social determinants of health and coordinate the care, refer the patients to NCCare 360. What we did with Latin-19 is to make sure that more of the Spanish-speaking community-based organizations that often were not included in this broad network were actually included to really align services for them. We have expanded to multiple key initiatives. The needs and concerns are so many. And what we have realized is that we created a space power, a space where people can actually speak and be heard. And then it's in that model that I presented earlier is the idea of thriving communities. As motion accelerates through strengthened partnerships and alliances, expanded knowledge, and improved health and healthcare policies and programs, assessing the impact of community engagement moves to the fourth domain of thriving communities, we're not there yet. Is our Latino community thriving well? In some examples, there have been. As shown in this graph, these are, when we started, this was part of contributing to that thriving, right? When we started doing vaccination events, if Duke was doing them, Duke University, Duke Healthcare was doing it where we didn't participate, 10% of those receiving vaccines started at 2% of those receiving vaccines in February of 2021, 5% to 10%. If we started bringing other community organizations in which we were also part of it, we went up to 21% of the vaccine for the Comunidad Latina, 27%, 26%. But if we were, Latin 19 was organized in the community event, and we did it in trusted places where the community felt really comfortable, we got the 97% of those vaccines were going to the community. They really started looking, communities started looking. They will travel from other counties because it was a Latin 19, Duke and Latin 19. What we realized there was the importance of creating that space that feels safe. Some ways was, si las doctoras están ahí, if those doctors, the representatives of Duke were going to be there, we're going to be safe. But that took time. And I also don't want it to be that if Viviana, Gabriela, Leonor, the ones that kind of drive this thing, we're going to be there. What we started going for is that everybody, we are all Latin 19. The idea that we are all working together, and that I'm going to speak a little bit about this tomorrow night. The idea that if one of us is hurt, all of us are hurt. Which group of people do we belong to? The idea of thriving community. Where we ended up as an outlier for the rest of the country is that Hispanics in North Carolina were the most likely to be vaccinated in the whole state. That movement that we started a year before we had access to vaccines really got to having Latinos being the most vaccinated. But this brings me to that issue of power that, David, you did not know I had this slide in here, but I did. What are the barriers to doing equity and racial justice work for our clinic, our health system, our organization? What are the benefits and burdens that communities experience with the issue? We talked a lot about burdens and benefits and who is accountable. And I have to say, I have often felt like I'm a horsefly. In Spanish, it's a nicer word. It's called a tábano. So we are all tábanos, right? Tábanos, that we are going boom, 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 until suddenly somebody says, oh yeah, I know this. We're gonna need to do this. But the work of health equity is hard. It takes constantly going there. And the day I walk away, I'm thinking, they got it. I think the health system understands it. We can, we had done vaccines. We are successful with the COVID vaccines, and then monkeypox comes. And then they call me, Viviana, we need your help to get the Comunidad Latina vaccinated. Okay, what do you want us to do? Can you start doing vaccine events? Sure, we'll do. Can I have the material in Spanish? Oh, we didn't think about it. Why didn't you think about it? Why didn't you think? The government didn't think about it. There was no material in Spanish about the COVID, the monkeypox vaccine. After 2 years of working on COVID, we should have learned this, right? My colleague Gabriela calls me and says, Viviana, I feel gut punched. A new tower went up, a new children's hospital tower. Durham is 14, 15%. Oh no, it went up to 17% Latino now. And suddenly the new children's hospital tower has one sign that says bienvenido, that says welcome in Spanish. I thought we were all in agreement. This was necessary. We have received every award from the health system for the work that we're doing. How about we, instead of giving me the award, you start putting signs in Spanish, right? It's this idea that we have to be consistent. One other thing that we did was we started creating these community consultation studios where researchers could get in touch with us, and then we would arrange for a consultation with members of the Comunidad Latina so that they could give advice for their research proposals. Often I get called, oh, Viviana, we're having a hard time recruiting Latinos. Okay, do you have material in Spanish? Oh, we didn't budget for that. You didn't budget for it? How are you gonna get members of the community who don't speak the language, right? So you have to budget, you have to think ahead of it. Back to that end slide, the beginning slide, health equity to transform systems for health. When community engagement takes place with core principles guiding its processes and activities, it propels strengthened partnerships and alliances, expanded knowledge, improve health and healthcare programs and policies, and healthier communities. Improvements in these domains and their associated indicators create motion and a catalytic action that moves us towards health equity and well-being through transformed systems. We hope to see the results. I hope to see multiple efforts all around the country. This was just one of them, the work that we've done with Latino. But we really need to think about how do we do this? And how do we include those voices in our own teams who, like me, for many, many years, like Viviana, you're always the one talking about those issues. Okay, I'm like, yeah, I am passionate about the issues that are happening to the Comunidad Latina because I see the disparities and I see the difficulties and I see the inequities. And as a health equity director, I often see it in Durham. The Black community has been for many, many years, very marginalized. And often, Northerners tell me, well, it's the South. No, it's the country. It's the world. This happens everywhere. It's just that we're not giving people the opportunity to voice what they have suffered or what they have said. And then we act together to make a change. Thank you so much. Muchas gracias.